So
Okay.
hi,
Oh, great.
everyone. Thank you for joining us. It's day 5, I believe, of Canadian Infertility Awareness Week. And all week long, Fertility Matters Canada has been bringing you lots of education through Facebook Lives, chatting with professionals in the fertility field. And today we're fortunate enough to have Dr. Ashley Gilman from Inova Fertility in Toronto. Welcome, Dr. Gilman.
Thank you. Thanks so much for having me. Happy to be here virtually. So, today's topic is about IVF 101. So, I don't know, I guess I'll just get right into it. Yeah.
Sure, just go for it, and I might
Okay.
interject with questions as we go through if they come on Facebook. So for everyone who's watching, just feel free to post your questions in the comment section of this video on Facebook, and we will try to get to as many as we can in the next half hour. All yours, Dr. Gilman.
Thanks. And so the presentation won't be the whole time. It's just like a few sort of basic slides, and then obviously ask questions as we go, or at the end it's more conversational, of course. So just briefly, we're going to talk a little bit about the female sort of fertility life cycle, and then go through some of the more specifics, like what is IVF generally, what is genetic like what kind of genetic testing do we have, or how do we know which embryos to use, what are the success rates, what can we kind of recommend, and then any questions that people have. And I think there's already a few questions that we had in advance too, so we can go through those at the end. Perfect. So this is a slide, and I think this is sort of more out there now. Like a lot of people that I speak with and a lot of patients that I speak with are more aware of this, but it's only sort of relatively recently that this has more been in the forefront. And so I think, not everyone is aware of this notion of how significantly, fertility changes for women over time. So looking at the first graph on the left, essentially this shows age is on the bottom on the x-axis, and then the y-axis is, so the solid line is pregnancy rates, and then the dotted line is pregnancies that end in miscarriage. So you can see as women get older that their likelihood of pregnancy decreases. And if they do get pregnant, their likelihood, unfortunately, of having a miscarriage with that pregnancy increases. So this is why, when we talk about fertility, women's ages are very important, or even the notion of sort of ovarian reserve can play into this as well. Not specifically from a miscarriage standpoint, but certainly from a likelihood of pregnancy standpoint. So then similarly, if we're looking on the graph on the right, which is specifically about IVF, it's similar, which is not sort of unexpected. So again, the red line is live birth rate by age. So you see that it decreases significantly, certainly like in late 30s, early 40s, and then drops off quite significantly in our mid 40s. And then the miscarriage rate similarly increases as we get older. And that graph is for women using their own eggs. So, this in some sense, I think it's important to also understand what IVF can and can't do. Certainly IVF is an excellent treatment, but it can't necessarily, it doesn't change the age of the woman, right? The underlying age of the eggs. So yeah.
Just a quick question, Dr. Gilman, what is the correlation between men and their fertility?
Yeah, so that's a great question. I mean, good news and also frustratingly, there's not as much correlation. There is some decreasing fertility with men as they get older, probably for a multitude of reasons, but the reality is that sperm regenerates essentially every 3 months. So there's less age issues for men from a sperm standpoint versus for women. I mean, the maximum number of eggs we have is in fact when we're a 20-week fetus. And then from then, the number of eggs that we have decreases over time, as well as the egg quality, which is another sort of factor with respect to specifically the miscarriage rate. There are some fertility issues, or certainly some other genetic issues that can come up with what we call advanced paternal age, things like autism, and there's like a handful of other conditions that we know are associated, but there's less effect certainly from the male's perspective, which is good in some ways, that we're not dealing with it coming from both sides if people are in a heterosexual relationship, but also is difficult because women, you know, their age is more important from a fertility perspective for sure. So very basically sort of talking about the IVF procedure, but more so even just sort of your pathway through, you know, sort of a fertility journey in general, typically starts obviously with like, you know, a referral, an initial intake, where you see a physician, they go through your history, and then usually we'll do what we call a diagnostic cycle or diagnostic cycle monitoring, essentially, where we do some basic fertility workup, and we tend to follow you through a cycle just to confirm that you're ovulating. We do this with a combination of ultrasound and blood work. So we confirm that, yes, there's an egg growing on the ovary. Yes, that egg is released. Your hormones are sort of doing as they should, all the while getting some other, you know, basic info about your underlying fertility and what may be going on if you're in a relationship and have been not successful in conceiving from trying at home. And then they'll come up with a treatment plan. And, you know, sometimes that treatment plan involves things like oral medication, ovulation induction, with timed intercourse at home, with insemination. Sometimes that treatment involves IVF, or sometimes you do a combination of those things. But essentially for IVF, this sort of ovulation induction part here, we also sometimes will call you know, stimulation or controlled ovarian hyperstimulation. Essentially, you're taking injections. They're similar hormones to what your body makes, but instead of making one egg a month, our goal is to make multiple eggs a month. Not too many, because that can put you at risk of something different called ovarian hyperstimulation, but just sort of the right number. So ideally something like 10 to 15 eggs, and then you go through an egg retrieval process, which is a small surgical procedure. We do it in the office. You have IV sedation, but you're awake and, you know, able to talk to us, and we're able to walk you through everything step by step. The embryologist will look at the fluid, like we're removing fluid from the ovaries. The embryologist will look at that fluid under the microscope to locate eggs. And then the mature eggs are then fertilized. So the diagram underneath essentially will show that they'll either be fertilized by what we call conventional IVF, when we put the egg itself in a dish with your partner sperm or whatever donor sperm you're using. And then that sperm, one of the sperm, hopefully, will swim and fertilize the egg. ICSI stands for intracytoplasmic sperm injection. And that's when an embryologist looks under the microscope at the sperm sample, selects a sperm that looks normal, and actually injects that sperm directly into the egg. Traditionally, ICSI had been used for male factor infertility. So when there's significant issues with sperm, and certainly we still use ICSI for that reason, but there's other indications or other reasons that we may use ICSI, but that's the idea of those processes, is to fertilize the egg. Once the egg is fertilized, it becomes an embryo, and then we typically grow that embryo to day 5, sometimes day 6, and then usually we will freeze the embryos at that age, and then sort of let you or the woman recover from everything that they've been through, and like from the stimulation process, from the retrieval, and then plan an embryo transfer, you know, as soon as the following month, but or later, depending on what that patient or couple decide together works for them. If you are doing genetic testing from the embryo, it's at that end stage, the day 5 or 6 stage, where the embryos are called blastocysts, that we take excuse me, that we take a sample, a biopsy from the embryo itself, to then grow those cells to see if there's any chromosome anomalies within those cells. And then later, as I say, we typically would prepare you for an embryo transfer in the hopes of having a baby, because that's why we're doing what we're doing.
Absolutely. Can I jump in with a question? Is that okay?
Yeah, for
Excellent.
sure.
How long should someone wait before they see a fertility specialist?
Yeah, so that's a great question. And I mean, generally speaking, we usually say that, you know, under 35, it's reasonable to try for up to a year at home with like timing intercourse, tracking cycles, and trying to conceive on your own at home. And then above 35, 6 months of actively trying. As women get into their later 30s and early 40s, potentially seeing someone sooner than that makes sense, just because we have a little bit less wiggle room and we don't want to miss an opportunity to be able to help. You know, the reason is, it's not that we have a hard and fast rule that like, oh, you've been trying for 11 months, so we're not going to see you. But we also want to, you know, we want to help people when they need help, but we don't want to be overly interventional and say, oh, you've tried for 2 months, so you need to see, you know, a fertility specialist, because there's a reasonable chance that if you keep trying, that you know, there's a good chance that you may be successful. So, you know, we have great treatments available, but we want to make sure we're treating the right people and not just treating, you know, anyone. That being said, there's obviously specific circumstances, you know, a woman who isn't getting regular periods or isn't ovulating regularly, if they know they have an underlying gynecological condition like endometriosis, or they've had, you know, an issue with their tubes, or for whatever reason, you know, that they're, again, if they're in a heterosexual relationship, that their male partner had, you know, previous testicular surgery, or there's, you know, there's always specific reasons. So certainly they could speak to their family doctor or a general gynecologist, and we would be, you know, we're always happy to see anyone at any point in the trying process. We sometimes even see people before they've started trying, but you know, we tend not to recommend IVF after someone's been trying for a month, you know, as long as everything else is normal.
Great.
So then, as far as like, a lot of times people have questions about which embryos are going to get transferred, and how do we decide? So typically the embryos are graded on day 5 or 6 whenever they're frozen. And this is very briefly sort of the grading system. So essentially, the embryos will be graded with a number followed by 2 letters. So the initial number is related to the cytoplasm, or like the liquid in the embryo itself. And it goes, it's graded from 3 to 6, with 6 being the best, essentially showing that the embryo is sort of hatching out, and then 3 sort of being the lowest, that there's really not a lot of sort of expansion of the cytoplasm itself. And so this grading system is done by embryologists. And I mean, I'll talk about this a little bit later, but certainly the quality of the IVF lab and the expertise of the embryologists is very important when it comes to doing IVF, because they're the people who are, you know, I mean, we do as little manipulation of the embryos as possible, but they're the people sort of taking care of the embryos, looking at the embryos, grading the embryos. So they're exceedingly important in this process. And they would be the ones, again, to grade the embryo. So then the second letter is the inner cell mass. So the inner cell mass is what ultimately becomes the pregnancy, or ultimately the baby. So this grading is from A to C, with A being the best and C being the least good quality. So essentially, A is like a very well-defined inner cell mass, and ranging to C is a more sort of poorly defined area of inner cell mass. And then the trophectoderm is the last letter, and those cells are ultimately what become the placenta. And so again, graded in the same way, and essentially just, you know, A is like that, the outer layer is very sort of uniform, that the cells sort of all look equal, versus the letter C would be that it's very irregular, the cells sort of look darker, there's some graininess to them. Again, this is all looked at microscopically. The trophectoderm is the area from which a biopsy is taken if a patient opts to do PGTA, or pre-implantation genetic testing for aneuploidy, which I'll speak about on the next slide. And so essentially, if someone opts to do PGTA, or again, pre-implantation genetic testing for aneuploidy, so that's a very long way of saying, so aneuploidy is essentially chromosome abnormalities. So, you know, as women, typically our chromosomes are 46XX. men's chromosomes are 46XY. So this screens for abnormalities within that chromosome. It doesn't screen for everything that could be wrong with a pregnancy. There's other types of genetic conditions that someone's chromosomes would be normal. And there's also, you know, anatomical issues or things that come up in a pregnancy that have nothing to do with chromosomes. But chromosomal abnormalities are the most common cause of miscarriage. So we know when someone has done PGTA and they have normal results, they're going to be less likely to have a miscarriage if we use that embryo than if they didn't have genetic testing, because a very common cause of miscarriage or an embryo not implanting, or again, having a miscarriage, is that there's a chromosome abnormality. So it doesn't reduce your risk to 0, but it decreases your risk of miscarriage. So if someone opts to do PGTA testing, then the biopsy again is taken from that trophectoderm layer. So the layer that becomes the placenta. So we don't touch the inner cell mass, like we don't touch those cells that ultimately become the baby. So as you can see from the slide, essentially, again, it improves embryo selection because we would only select to transfer an embryo that was chromosomally normal. There's some cases where we'll transfer what's called a mosaic embryo, which has some minor chromosomal abnormalities, but those are specific cases, and patients get spoken to by a genetic counselor, and it's you know, a little bit more complicated of a process. And then embryos that are abnormal essentially don't get transferred. So this supersedes the embryo grading if it's done. If it isn't done, then we typically will transfer the best quality embryo based on embryo grading first, and then move down if there's additional embryos. So yeah, so essentially reduces your chance of miscarriage. It's not 100% preventative, but it will decrease your chance of miscarriage. As I said, it screens for chromosomal abnormalities. It's still felt to be a screening test. It's very accurate, but it's not 100% accurate. Typically, if we know that there's a what we call euploid or chromosomally normal embryo, then we'll just put one in at a time. So therefore, people are getting singleton pregnancies, as in one baby at a time, which we know is always safest for mom and for baby, okay? Because it decreases all obstetrical risks, but the highest thing that it decreases is preterm delivery, which can happen with one baby, but the chance of that increases with 2 babies and certainly with 3 and beyond. And then, so can save money and heartache. I mean, that's mostly certainly related to the risk of an embryo not implanting or having a miscarriage, and then the potential cost saving of having to go through multiple embryo transfers that don't result in a successful pregnancy. And then, yeah, so similarly, that preventing critical time from being lost. And then there is this advantage because you're less likely to have a miscarriage, that then if you have more than one embryo and like euploid embryo, then depending on how you want to time potential pregnancies or time between potential children. But as it says, it can't change the quality of the embryo, and we can't change the chromosomes, like we can't change the genetics of the embryo. So this is like a very brief slide on the process itself. So again, PGTA is done, the biopsy is done on day 5 because or day 6, because the biopsy has to be done when we actually have a formed blastocyst. So you can see on the top row, the very last image there that says day 5 blastocyst, you can see that there's sort of a formation of cells in the bottom part there, which is the inner cell mass. And then these cells that go around the top part of the circumference of the circle are more just sort of outlining the line there. And that would be what the trophectoderm is. And that's where we take the biopsy from. So that's why we can't do PGTA earlier, because we need to take a biopsy from the trophectoderm, and earlier than day 5, there is no trophectoderm to biopsy from. And then step 2 just shows the biopsy being done. So again, it's a very technical thing, again, highlighting the importance of having skilled and experienced embryologists to be able to do this biopsy for you. Step 3 is just showing the chromosome analysis that gets done at the lab. And then step 4 is the results. And step 5 is hopefully the pregnancy and the baby.
That's great. Sorry, I wasn't sure if you had another slide. Did you have more slides?
Oh no, I do. I think there was, yeah. There's a few more. I think there was just a technical glitch there. So yeah, so then As I said, so we grow the eggs up to 6 days, sometimes rarely 7 days, depending on how they're growing. And then ideally, we transfer one at a time. And if we know that that embryo is euploid or has normal chromosomes, then that's great, because that will decrease or increase your chance of successful pregnancy. Typically, if we're doing an embryo transfer, most often we use a hormone medication called estrase to thicken the lining of the uterus and prepare it for embryo transfer. And then a few days before, depending on the age of the embryo, we add in progesterone to help support the pregnancy. And then we plan the embryo transfer. And the embryo transfer process is typically much more straightforward than the actual process of egg retrieval. I mean, it's not painful, so there's no sedation associated with it. You know, you come in, you have an ultrasound done on the abdomen, like on the outside, and then we put a speculum inside, like when you get a pap test done, and then it's supposed to be, you know, quite a painless process, where we then put the embryo in. And, you know, at our clinic, you can see both on a screen sort of what the embryologist is seeing to prepare the embryo, and then what we're seeing on ultrasound. And we send you home with a couple pictures. So yeah, the most uncomfortable part is that you have a full bladder. So yeah, so as I mentioned, like the highest success rate is if we do a pre-implantation genetics testing for aneuploidy, typically with next generation genetics, like next generation sequencing screening. But again, there's no guarantee. Even with a chromosomally normal embryo, we can't know 100% that will result in a pregnancy and a healthy baby, which is obviously our goal. Yeah, so you're going to have higher success if you have either a screened embryo or an embryo with a higher grading. And yeah, so there's about a 35-40% success rate per transfer in Canada, and then you know, a 64% successful or like percent successful pregnancy if we were transferring a euploid or chromosomally normal embryo.
You mentioned earlier that, you know, typically we transfer one embryo at a time. Are there any circumstances where you may transfer more than one?
Sometimes. I am a large advocate. I think a lot of REIs are for what we call elective single embryo transfer, because we know that multiple pregnancies have higher complication rates. And as I said, our goal is to have healthy babies. But yes, there's certain, I mean, we'll speak a little bit because there is some funding available for IVF in Ontario. And so if a patient's doing a funded cycle, there's very specific guidelines that we have to follow as far as how many embryos to transfer. And the focus of that is really to transfer one embryo at a time, again, because of the risk of complications if we do have a multiple pregnancy. Certainly if we've done genetic testing and it's normal, then generally we would opt to just transfer one at a time. But for sure, there are circumstances, like absolutely have done double embryo transfers, but they're, you know, I mean, it's sort of like a case by case thing. It's not that it's not possible. It's just that it's not routine.
Got it.
So as far as success rates are concerned, this chart sort of highlights the difference between IVF and IUI, or intrauterine insemination, which is another commonly used technique by fertility doctors or at fertility clinics. And so, I mean, in some sense, this also highlights the initial slide that I showed with respect to the change in a woman's age and the effects on the fertility or on their fertility. So we can see that, you know, at any age, IVF is more successful than IUI, and IUI success rates are similar. They do decrease for sure, but IVF cannot do everything, right? Like that we certainly still have success at 40 or over, but our success rates are under 10%. So that's certainly not zero, but it's not as high as, you know, as 40 or 50 or 60% that we get when we're younger. So.
And just to confirm, this is when the eggs are retrieved at these ages, not the age of transfer, right?
Yes, that's correct. So everything that we sort of talk about when we talk about IVF and success rates are all based on the age of the egg. So if someone did an IVF cycle when they were 30 and now they're coming, when they're 42 to use those eggs, those are still, they would have the success rate of a 30-year-old because that's when the eggs were frozen. Similarly, if someone, as an example, is using an egg donor, their success rates would be related to the age of the donor as opposed to the age of the woman who's having the embryo transferred.
Great. We're getting a couple of questions, if I can interject just to make sure we
for sure, of course,
get to them. Well, the first is, why would one go through IVF versus IUI?
Yeah, so I mean, so first of all, certainly the success rate for IVF for all comers is higher, as like I don't know, Liat, if you can go back even to the last slide. So we know that the success rate is higher regardless of your age, but IVF is a more, invasive process. There's more risk and side effect. And then there's a cost piece too, of course. So it's not that I, would recommend that everyone I see goes through IVF, but I still do explain that the success rates are as they are. So usually we go in a stepwise approach. Again, it depends a little bit on other underlying factors, like a reason to go straight to IVF. There's some reasons to go straight to IVF, like a woman has blocked tubes or no tubes, or there's the sperm is very poor, or there's no sperm and we have to do a testicular sperm extraction. Or sometimes in cases where there's severe endometriosis, not always, but sometimes. And so there's some specific cases where we would sort of go straight to IVF, but in the majority of cases that we see, we tend to go in a stepwise approach where we sort of start sometimes with oral medication and timed intercourse at home, sometimes with a combination of oral and injection medication. The injection medication is the same medication that we use for IVF, but we use it at a much lower dose with a goal of making sometimes 2 or 3 eggs a month to kind of increase the target with the sperm. And then we would often combine that with IUI or intrauterine insemination or artificial insemination that has, all sorts of names, and then, move on to IVF. Certainly, I mean, as I said, the success rates are as they are, but we do have lots of couples who are successful with IUI, and then, IVF, as I said, it has more risk and side effect. So it's a very effective treatment. And it's not that we shy away from doing it, but it's also that we recognize that, it's not a treatment for everyone, and we can have successful pregnancies in other ways as well.
Are the success rates on this slide here, are they with PGS testing, or I'm not sure of the new acronym. I think I forgot it. But
it used to be testing? PGS. Yeah. I don't think so, actually. Liat, do you know? But I don't think so, because I think they're higher with PGTA.
No, I don't have this information. We can check that. We can verify.
Yeah.
Right.
We'll let you know then.
And how many healthy eggs are usually retrieved, which then in turn become viable embryos for potential implantation? So I know it would differ woman to woman, I would imagine, but how many eggs do you need to have enough embryos to have what you would call a successful IVF process?
Right. So that's an excellent question that we don't have a definitive answer for. And by that, I mean, like I speak to my patients all the time. Like we could have 20 eggs and no pregnancy or no baby, and we could have 1 egg and have a baby. But certainly statistically speaking, the more eggs we have within reason, because we don't, there is a phenomenon called ovarian hyperstimulation syndrome, or OHSS. And so we don't necessarily want to push women too much, because then first of all, they can, like, my primary goal is to keep women safe and healthy, right? So I don't want to do anything that's going to jeopardize, you know, my patient's health. So we do our best to avoid ovarian hyperstimulation syndrome. And in addition, we know that if we push too hard and get too many eggs, often the quality of those eggs and those embryos is not as good. So, I mean, health is primary, but secondarily, we know that again, too many eggs may not actually improve our chances. I mean, I would say the ideal is probably between maybe 10 and 15 eggs. We know that there's sort of attrition at every level. So as you go through a stimulation process, we monitor you with ultrasound and blood work. And then we can see the follicles growing on the ovaries. But I always explain that, you know, when we do the egg retrieval, not every follicle that we see has an egg inside. And not every egg that we retrieve is mature. And not every mature, because we fertilize typically only mature eggs. And not every mature egg will fertilize normally. And then not every normally fertilized egg, or now it's called an embryo, grows into a healthy day 5 blastocyst and or has normal, chromosomally normal genetic testing if it's done. So there's sort of attrition at every step. And that's just stopping at the day 5 mark, right? So then beyond that, it's not all of those embryos then, you know, implant or become healthy or result in healthy pregnancies and healthy babies. But yeah, I mean, somewhere between, I guess, like 10 and 20 eggs, more so, I would say. But sometimes we don't know. Sometimes we get 15 eggs and we have no blastocysts. I mean, rarely, and that's not the outcome that we want, but sometimes we have 2 eggs and we get 2 euploid embryos, right? Yeah.
Yeah, I think in my IVF experience, I tend to be someone who made a lot of eggs and it didn't work out well for us. Whereas, you know, I have a friend who made 2 eggs that turned into 1 embryo and is her daughter. So you're totally right. We have, you know, obviously you're right. You're the doctor.
Well, there's things, you know, that we don't know.
Yeah.
But yeah, exactly. And again, and even cycle to cycle and can vary. And sometimes the other thing is sometimes we get more information when we do the retrieval, like the embryologist will actually look at the eggs. So we might get a good number of eggs, but when the embryologist looks under the microscope, sometimes, because we don't have a great test to assess for egg quality, the best indicator is age, but we don't really have a good test for it. So even if we get a good number of eggs or a certain number of eggs, the embryologist, they may not result, you know, as you just described, necessarily in embryos and or in healthy embryos. And then and sometimes they will comment that the eggs, you know, on certain aspects of the eggs that may reflect their quality. So that's information. Sometimes we get more like diagnostic information when we do an IVF cycle, which can be informative to patients and to couples, but that's not a reason that I would recommend doing IVF, but it's certainly some additional information that we can provide to patients, because, you know, this journey absolutely can be frustrating, especially when we don't always know why people aren't successful in getting pregnant. So there can be some information provided that way. Okay, and then, oh yeah, thanks, Leanne. So essentially the factors affecting IVF success, I mean, there are many beyond this, but like, so the receptivity of the endometrium. So again, we sometimes will do natural cycles where women will sort of ovulate on their own and will time their embryo transfer with their ovulation. Most commonly we do medicated cycles. And so then we provide exogenous, or like you take yourself, estrogen to prepare the lining of the uterus, and then progesterone to support the pregnancy. And that can affect, and so that is kind of ensuring that the endometrium hopefully is sort of receptive to implantation, that it's timed properly. The embryo quality, as we discussed, or if genetic testing has been done on the embryo. And then the lab quality is very important, as I've already sort of touched upon a little bit. Because yeah, I mean, labs can make a huge difference, as you can see from this slide, where, you know, their birth rates are essentially, I don't know, 20% higher in one clinic to the next. And there could certainly be other variables, right? Because not every woman is comparable to another. There's age differences, there's, but there's differences in BMI or underlying diagnoses, sperm quality, but absolutely the lab is very important because, growing those embryos, monitoring those embryos, doing the ICSI, if you have ICSI done, the type of conditions that they have in the lab to sort of culture the embryos and grow the embryos, potentially doing a biopsy on the embryos, those things are exceedingly important. And so the lab makes a very big difference. So it's a very important thing to sort of, ask about and inquire about at a clinic that you're looking into is what the lab success rates are, kind of how things are done in the lab, to get an idea about that and kind of educate yourself about that.
This is I was literally just going to ask you, how do you know if the lab is good? Like, what questions should you ask? And then you had a slide prepared for me.
Yeah. So essentially, exactly. So yeah. So having your own lab is great, because then that the clinic, like the physician you're seeing, probably has first of all, the lab is there. They have direct contact with the embryologist. Like I talk to our embryologist like almost every day, and our head embryologist is available if I have, I also often talk to him most days. So just that communication piece is hugely important. And then also, because then you can all sort of communicate together if any changes need to be made, or reviewing the evidence of what you guys, your success rates at the lab, at the clinic, et cetera. It's hugely important. And then, yeah, just sort of how much experience does the clinic have? How many cycles are they doing? What kind of embryo culture conditions are they using? And not that that a non-medical or even many physicians wouldn't know, like aside from fertility physicians, like you don't need to educate yourself on what the most optimal condition is, but even asking that question will give you some idea, depending on how it's answered, about how things are done in the lab. And then other things like, how many embryos are transferred in a fresh cycle, as in, so a lab that is confident about their lab techniques often will do frozen embryo transfers, because they're less worried about, they're confident that the embryos that they freeze are of good quality, that they're going to survive the thaw and have good success rates. And around the world, frozen embryo transfers have a slightly higher pregnancy rate than fresh embryo transfers, for a multitude of reasons. But that can be sort of a good way to suss out, the quality of the lab. It's not a perfect question, but that can be helpful. Yeah, so those types of things. And yeah, so again, it's because a lot of what is done in the lab is technical. And then I saw, a question about like why genetic testing is expensive. So a lot of that is about the technical aspect of doing the genetic testing. Like it's very technically involved, as far as like the equipment that's needed, the expertise of the embryologist that's needed, and then just the ability to sort of grow the cells in a lab. So that's like grow the cells later to assess for any genetic or chromosome abnormalities, and the culture media that's used, and how those cells are grown and reported. So that's why it's expensive. Yeah, I think, oh yeah, this is just some pictures of our clinic.
Beautiful.
Thank you. Yeah, it's very lovely. Yeah, and then I think, is that it? Yeah, okay. Perfect.
Great. That was so informative. We have some people commenting online about how informative it is. So thank you so much for sharing those statistics with us. Very helpful statistics, and also answering questions. I want to be conscious of time. So maybe we could go with one more of the questions that we've received. So I'm reading one here that we missed from earlier, which is, I've read that IUI is not superior necessarily to medicated timed intercourse. What is your professional opinion on that?
Yeah, so I think, again, like a lot of things, it's sort of it sort of depends on the circumstances. That can be correct, like in the setting of a normal semen analysis, and then timed intercourse certainly, or doing IUI doesn't necessarily add a lot above timed intercourse at home. Certainly with the oral medications, there's some evidence, like there's some studies about specifically about patients with unexplained infertility. So unexplained infertility is when, you know, all the workup has been done and we can't find, you know, a reason that people aren't conceiving. And that could be because there's nothing wrong. And if that couple continued to try, that they would conceive on their own. And it also could be that there's just a lot of things about fertility that we still don't understand. And that we're sort of limited by the testing that we have. So as an example, in couples with who have unexplained infertility, if we're using injection medication, then there's good evidence that, you know, even in the context of a normal semen analysis, that doing IUI, if someone's using injection medication, seems to improve pregnancy rates. Again, why that is, I don't necessarily have a reason I can show you on paper. It's most likely related to the fact that there are things about fertility that we just don't completely understand. But I would say that I don't think IUI, I mean, I'm not a physician who thinks that everyone needs to do insemination, but you know, it's always a discussion that I'll have with patients, and certainly in specific circumstances. But the results can be equivalent, certainly in the setting of a normal semen analysis, as I said.
Great. I want to end on a really positive note. So sorry to anyone whose questions we haven't gotten to, but we're nearing the 45-minute mark. Just to end really positively, do you have any tips? Do you have any tips to help an IVF cycle be more successful?
Yeah, I mean, well, first of all, what I say to most of my patients, just generally speaking, is like fertility, you know, going through infertility and coming to a fertility clinic is inherently a stressful process. And all of my patients are stressed, and then they're stressed out that they are stressed out because, you know, but everyone is stressed. So first of all, do your best. Like if you can reduce stress in your life, that's great. That's great for your overall health, for your mental health, maybe for fertility, although I'm less convinced. Like I think what I really tell patients is like, don't stress about being stressed, but do what you can to sort of de-stress. And that goes into other things that may sort of help. So that's like finding a support network. So whether that's your partner, family members, friends, you know, through ANOVA, we have online support groups. There's also fertility counselors that you can speak to that have a lot of, you know, so finding your support group and relying on them. The other things are very sort of basic, like lifestyle stuff. So trying to maintain, you know, a healthy diet, exercise, a healthy weight, you know, no smoking, no recreational drugs, no alcohol, or certainly alcohol in like very limited quantities, and then not during your IVF stimulation, you know. And then there's obviously a financial piece, so sort of sorting that out, as far as, you know, speaking, if you have drug coverage, speaking to your insurance company to find out what's covered and what isn't, and what you kind of need just to make that process, you know, less stressful. And then you know, I always tell all my patients to be on a prenatal vitamin and folic acid. Ideally, you want to be on that 3 months before you conceive. So if you're sort of starting this journey and you haven't started on it, I would start on it. And then, and just sort of informing yourself, like asking questions, like that's what we're here for. You know, your physician is here to support you. There's a team of nurses, of administrators. There's, you know, people at the clinic to support you. So if you're struggling or you have questions, then reach out, because knowledge is power. It's going to help you feel more comfortable and, you know, hopefully lead you to success.
Great. Thank you so much, Dr. Gilman. We really appreciate you coming and spending the time with us and giving us such great and useful information. You know, there's still more questions flowing in, so maybe you're willing to come back another day and answer some more questions for us.
Can I
I'll
ask?
see what I can do. Yeah.
Can I ask, please, to download the questions so we can get the contact details of the people who reached out with questions, that we can get back to them, because that will be helpful. Dr. Gilman will be able to maybe reach out and
yeah, that's what I was
answers.
going to say. I can try to get to them, even if not on like a session, but just to get back to people.
Perfect. Yeah, that's, oh, thank you so much. What a wonderful offer. Yes, we will absolutely send you those questions.
Great.
So thank you so much. And thank you for everyone who's watching today. I believe we have more events tomorrow as well on Facebook Live. So check the Fertility Matters Canada Facebook page to see what's next on the schedule. And if you have any ideas for topics that you want to cover, please just reach out. We're more than willing to help set things up based on what you tell us you need. So thank you again, Dr. Gilman, for joining us. Thank you, Liat, for running the slides. And hopefully we'll be able to speak with you soon.
Great. Thanks for having us.